And thank you very much for asking me to come here today. I ought to really introduce myself because Tony knows me quite well, and there are a few people from the Milton Keynes congregation that also know me. My name is Adrian. I originate from Cornwall, from the west of England, in rural Cornwall, and I trained in medicine at Guy's Hospital in London between 1967 and 1972. Which seems like quite a long time ago now, really. Yeah, I know I don't look it, but that's yes. After doing some various hospital jobs and spending a stint in Scotland, in the Livingston New Town as a trainee GP, I moved to Lowestoft in Suffolk, where I spent 4.5 years, and then in 1981 we moved to Milton Keynes, where I was to set up a new practice in the centre of the city. So we started with virtually no patients, and then we gradually built up over a period of about 5 years to about 12,000 patients. So the growth was pretty spectacular, and it's a good business opportunity to go into a new town and take on patients, because nobody there has got a doctor, so they have to come to you anyway. So there's not, it's not a particularly difficult task to achieve. So, and over that time we built a couple of surgeries. We built one right in the city centre, which has now been demolished, although we'd moved out several years previously. And then we moved to a local housing area, so we had more car parking, a bigger building and everything. So, and the association with your congregation is that for many years we had a congregation that met at our church in the afternoon from the local Chinese church, or one of the local Chinese churches. They outgrew us, so we didn't have enough space to accommodate all the things that they did. So we lost them around about the time of the pandemic. Of course, we couldn't take anyone on during the pandemic, but we were approached through a minister at Christ the Cornerstone, George Moara, to accommodate your congregation. Your Milton Keynes congregation. So we've done that very happily now for about just over a year. And it's been a really good association, I must say. It's been you folks are absolutely great as tenants. I'm not your boss; I'm your landlord, really. So.
Back in the church.
No, I get bossed around by other members of the congregation. I'm pretty easy, really, generally. So, so I've been retired now from practice for over 10 years. So it's a bit of a government health warning today, really. So I'm not completely au fait with the latest in research, and some of the drugs that I've been reading about. In fact, I've never ever had to prescribe because they didn't exist 10 years ago. So this is a kind of basic discussion about diabetes and its causes and what to look out for. So I might start just by asking you how many folk here, if you're willing to share. I don't expect you to, if you're embarrassed about it, don't. But how many of you actually do have diabetes or being treated for it? 1, 2, 3, 4, 5. Yes, that's not particularly high, is it? So I was astonished to read that the incidence of diabetes in the UK currently has topped the 5 million mark. And if you think our population's 60-something million, it's something like 1 in 12 of the population. And when we talk about ethnicity and diabetes, there's quite a picture to that, because people, particularly from South Asia, that's Bangladesh, Pakistan, India, and Sri Lanka, have about 4 times the incidence of the local UK population. And people from Africa or Afro-Caribbean people have about 2 to 3 times the incidence. So you're looking at, amongst your communities, you're looking at, 1 in 7 or something like that, aren't you? So that's an awful lot. I think years ago when I trained, we reckoned that there were about 3% of the population had diabetes. Now it's more like 8%, 8-9%. So that's quite an achievement. But I think it's largely because diabetes is better known, a lot of people must have just lived all their lives, or a big chunk of their lives, without even realizing that they had it. And now, because we're much more aware of it, we're much more aware of the complications and things that can arise, that the rate of diagnosis has gone up, which is a good thing, because by diagnosing these things early, you can actually limit the complications and provide effective treatment. I have a very strong family history of diabetes. My father had it. I had 2 aunts that had it. My grandmother had it. Fortunately, so far, I've been fortunate and not had it. I think I must have inherited my mother's genes, because there's no history of diabetes at all on my mother's side of the family. So I'm pleased about that. But thank you for sharing that with us. So what is diabetes? Basically, just a basic definition, it occurs when the body can no longer control the level of glucose in the bloodstream. That's glucose being sugar. Glucose is essential to life. It's as essential to life as oxygen. But too much of it, and it can cause quite a lot of damage. The levels of glucose are controlled by insulin. I don't expect you find that a new bit of information. And the hormone is actually produced in the pancreas. We didn't see the pancreas in the pictures that you showed earlier on. I've got one in the moment. It's not quite as gory as your picture, but and the pancreas is an organ situated close to the stomach, and it has 2 main functions. Part of that is the digestive function, because the liver, which produces the bile, and the pancreas empty into the gut at the same point. They actually join up in a sort of Y tube and go into the gut. So the liver produces some hormones, and it produces some digestive enzymes and the bile that you mentioned. And the pancreas also produces enzymes. So that's one of the functions. The other is this production of insulin, and that occurs in parts of the pancreas called the islets of Langerhans, which are little kind of groups of cells within the pancreatic body, and they secrete the hormone directly into the blood. Now, that's not quite so gruesome. This is it. Yeah, that's basically where the pancreas sits. So it's under the liver. This thing that looks like a comma there, that's actually a diagrammatic representation of the gallbladder, where the bile is stored. And the pancreas enters the gut just below the stomach, and then it secretes the hormone into the circulation. Now, I expect you're familiar with the types of diabetes. The first one is type 1. That's we used to call it insulin-dependent diabetes, or juvenile onset diabetes. Juvenile onset implies that it occurs in children or infants or very young adults. That is largely true. Most people with juvenile onset diabetes or type 1 diabetes do get it before the age of 20. But it's by no means always true, and I have seen diabetics being diagnosed with type 1 diabetes well into middle life, sometimes into older age. So it's still possible to get it when you're older. Now, of the number, the 5 million or so that have got diabetes, about 8% of those have type 1 diabetes. So it can occur at any age. Most occur in childhood. And of course, the longer you live with diabetes, the more likely you are to get complications from it. So someone who gets it very early in childhood, even babies can get it, will have a lifetime of having to control their diabetes in order to try and minimize the complications. And I'll come along to the complications a bit later on. The type 2, which is the most common, that's around 90% of people with diabetes. We used to call non-insulin dependent diabetes, or maturity or adult diabetes. Usually comes on in middle age, but it has been getting younger. And particularly amongst the ethnic groups that we've mentioned, the tendency for type 2 diabetes is younger than it is in the white ethnic population. And also at a lower weight. So you're not only afflicted by, you get it earlier, and you also get it without getting quite so big. So the other types are a few rarish ones. Gestational diabetes commonly occurs in pregnancy. And it can be quite severe, in fact, and sometimes requires insulin treatment. And it often occurs in subsequent pregnancies as well. My wife's got a niece who has recurrent gestational diabetes, and they often go on to develop type 2 diabetes later on. She hasn't yet. And there's also this condition called prediabetes, or impaired glucose tolerance. That's where the levels of blood sugar are above normal but are not sufficiently high to make a full diagnosis of diabetes. But these people are also at some risk of developing complications. So if you're diagnosed with that, you should take the same kind of precautions to look after yourself as would someone with type 2 diabetes, although you might not need any medication. Now, symptoms of diabetes, these are not always the case, and you can quite often have no symptoms whatsoever and be diagnosed when you end up with some kind of complication. So it's not unusual, for instance, for somebody to go into hospital having had a heart attack and to find that they've actually got diabetes that they didn't know about. So the complication actually comes before the symptoms. But classically, the symptoms of increased thirst. And that's really linked with this polyuria, or frequent urination. The reason for that is that the sugar gets into the urine, and the body therefore produces more urine. It's a sort of osmotic physical process, if you like. So you're passing more urine because it's kind of sugared. And that, of course, will lead to increased thirst. And this is particularly true in young type 1 diabetics. You get increased thirst. They're often polyuria. So if you're not having to get up at night to pass urine, you've probably not got diabetes. But that doesn't necessarily follow. The other thing that's a common early symptom is blurred vision. And that too is a physical process because the sugar gets into the liquid that's in the eyes, the aqueous and the vitreous humor, if you remember your sort of O-level biology or whatever. And that affects the refractive properties of the eye. So if you have blurred vision and you're diagnosed with diabetes, you shouldn't actually do anything about getting your specs changed until your diabetes is properly controlled, because it may well get better on its own once the diabetes is properly controlled. In type 1, weight loss is quite frequent, again at any age, because it's a sort of hypermetabolic state, if you like. So you lose weight in the same way as you perhaps would do if you had an overactive thyroid. So I think there were 3 T's. It was thirst, toilet, and thinner are those sort of classic symptoms. Sometimes people actually present with diabetic ketoacidosis. Now that is a severe complication. I'll talk a little bit about that later on. But it's when the disease is quite fulminating and the blood sugar goes very high, body can't metabolize sugar, so it then starts to eat away at the body fat. The body fat contains a lot of acetone, which makes the blood very acid, and people can become very ill very, very quickly. Now, the other thing that often happens is, and you often find this when people present with these sort of things, is frequent skin infections. Things like thrush, for instance, are very common in diabetes because these bugs kind of like sugar, so they accumulate wherever everything is sugary. So particularly fungal infections, the sort of urogenital infections and that kind of thing are very, very common. But also boils and abscesses for the same reason. So it's not unusual to find somebody comes in with a big thumping abscess to your casualty department in hospital. First thing you do is to check that they've got not diabetic, because the skin infection is often due to diabetes. You get other sort of vaguer symptoms like tiredness, loss of energy, sleeplessness, that kind of thing. Quite important for looking after yourself are these last two, which are numbness of the hands and feet, and that's caused by a condition called diabetic neuropathy, where the nerves are damaged in some sort of way by the high levels of sugar, and also impaired circulation. So the arteries tend to narrow, so that the reason why people get strokes and heart attacks and things is because of this narrowing of the arteries, because of the increased risk of atheroma, the effects of high cholesterol, etc. So those are the sort of main cardinal symptoms, but you may not get any of those. You may not have any of those at all. It may be just kind of creeping up on you. Now, how do we diagnose diabetes? The current standard is still, I think, and this was when I was in practice, and I think it's still the same standard from what I've been reading, is if you have a random blood sugar level above 11.1 millimoles per litre. So if you go to your doctor, they take a blood test, regardless of whether you've eaten or not, and it's sky high, over 11, then the chances are that you have diabetes. And at that sort of level, you will also have sugar in your urine. In fact, that used to be the standard test. In fact, people used to look after their diabetes by testing their urine. But the urine doesn't necessarily have any relation to what's going on in the blood. But it's still a simple and quite easy diagnostic test to do. So, somebody presents and you just stick a sticks in their urine sample and find they've got glucose in there, they've almost certainly got diabetes. There are one or two other reasons why they might have that, but won't go into that. Fasting blood sugar should be above 7. That means after an overnight fast. And the other test that we often do is a sort of glucose challenge. We used to call it a glucose tolerance test, and we used to give people sugar after a fasting blood test and take the blood every half hour. Really, the only figure you were interested in was what it was after 2 hours. And if that is over 11.1 after a 75-gram glucose load, and glucose itself, when you try and take it, is a pretty sickly tasting stuff, isn't it? So we used to give them Lucozade to work out how much 75 grams of Lucozade was. And the other test that's frequently used nowadays, apparently, and wasn't so much used for diagnosis when I was in practice, is the HbA1c. And that, if that's above 6.5%, or 48 millimoles, that is almost diagnostic of diabetes. So we used to use it more for maintenance and care, and to see how people's diabetes was being controlled rather than as a diagnostic tool. But it does seem to be used more nowadays as a diagnostic tool. And the reason for that is that when the sugars are high, the sugars attached to the hemoglobin, which is the stuff in the red cells. So below a certain level, if it's below 6.5%, you're not likely to be diabetic. If you have persistently raised blood sugars, more of it gets attached to the hemoglobin, and therefore the percentage of hemoglobin that has this glucose attachment to it gets higher. So it's a good way of telling whether someone's over, say, 3 months has had good control of their diabetes or not. Where are we? Other useful tests. I've already said about the urine test. What's important, particularly in type 1, are the ketones. Ketones are the stuff that appears in the urine when you're breaking down your fat. And that's particularly relevant for the diabetic ketoacidosis. Now, if someone has got ketones in their urine, they've almost certainly got type 1 diabetes. They won't have type 2 diabetes with ketones in their urine. Protein is important because one of the complications of diabetes is damage to the kidneys. And protein in the urine is a very good test, very good simple test of whether there's a likely problem with renal function. Eye examination is also important. The back of the eye in diabetes can become very inflamed, and the vessels themselves can become inflamed, and you can develop more blood vessels in the back of the eye than you need to have as a response to the diabetes. And that is really quite damaging to your sight. It's called diabetic retinopathy, and it's often now treated by injections into the eye. Well, I've had injections into my eye, not for diabetic retinopathy, but for, and every eye looks like that, you know. They all think they don't. When you say, well, I've had my cataract removed, nobody bats an eyelid. If you say, oh, I've had an injection in my eye, they go, oh, you know. But that's ophthalmic examination is very important, and it's part of routine care that you do get regularly seen by an optician and have your eyes tested, but also have the fundal examination with a slit lamp and everything, so that they can have a look at the back of the eye, and also to check to see whether you've are developing cataracts, because that's another possible complication of the diabetes. Limb sensation is very important. We'll come on to that a little bit later, but that's I would say the neuropathy. What seems to happen is that the blood vessels supplying the nerve are damaged in some way, so therefore the sensation in your limbs gets less, particularly in the feet. Can happen in the hands as well, but particularly in the feet. Kidney function tests we talked about, blood pressure and ECG. You know, these things are multifactorial. So blood pressure, if you've got diabetes and you've got raised blood pressure, then that's a double whammy, really, because you've got more risk factor. Blood pressure alone has an effect on your blood vessels. If you add diabetes to that, that's not good news. ECGs, etc., to check on cardiac function. The kidney function tests, things like measuring blood urea and creatinine to check to make sure that you're not going into renal failure, is also important. And then, of course, you know, you want to make sure that you're not having raised levels of cholesterol in the body as well. So cholesterol, triglycerides, and other fats are important. Causes, genetic. Largely in type 1, possibly also in type 2 diabetes. So if you've got a strong family history, and we've talked about the greater disposition in the different racial and ethnic groups. The bad news, as I say, is that you can also develop it at an earlier age, from 25 as opposed to 40 for white ethnics, and also at a lower weight. So treatment. Type 1 diabetes always requires insulin. So if you have type 1 diabetes at any age, you will require insulin treatment. There's no question about that. And that's given by regular injections or by a pump. And a little bit further down the list, we've got the artificial pancreas. That's a new innovation in the last few years. Basically, it's a combination of a pump with some form of regular monitoring, which is done automatically. So you don't have to test your blood in order to do it. It gets done by a machine, which then feeds the necessary amount of insulin into the blood. So it's kind of replacing the pancreatic function. Those of you who are diabetic may be familiar with the treatments, particularly the oral treatments. I say there are others that have come online since I was in practice. The always first line was metformin. It's a safe drug. Sometimes gives problems with gut problems. Metformin. It causes a sort of IBS type syndrome in some people, but it's safe. It doesn't cause hypoglycemia, which is the too much lowering of the blood sugar. Glibenclamide, gliclazide, and others. Important to maintain an ideal body weight. That means really a body mass index below 25. So that's, from me at 5'6" is about 11 stone. For somebody who's about 5'10", it's about 12 to 12.5 stone. So just to give you a sort of round figure of where you ought to be with your weight. But the other interesting thing is this business about bariatric surgery. Now, do you know what bariatric surgery is? It's surgery for weight loss. So people who are morbidly obese or significantly overweight can have surgery to bypass part of their stomach. And for some reason, and I don't think it's been fully explained yet, it seems to have an overnight effect on type 2 diabetes. And people can wake up the next morning and find they no longer are diabetic. You know, it's that unusual, it's that remarkable, really. And I don't think the mechanism of that has been fully explained yet. And then there are these newer kind of things. You can have your some islet cells transplanted, or you can have whole pancreatic transplants. But that's something fairly new. Complications. Yeah, hypoglycemia. This is when people, particularly those on insulin or on medication, develop very low blood sugar levels. I don't know whether anyone's experienced that symptom. Have you ever? Usually people complain of confusion. They may get giddy. They start to sweat. And in more extreme circumstances, they lose consciousness. And that has to be remedied quite quickly, because hypoglycemia is actually quite dangerous and can cause permanent brain damage if it's not reversed. So the usual thing is to give someone who's getting early symptoms, give them a good sugary drink or something. But there are things like hypostop, highly concentrated sugar that you can inject into someone's mouth, which will absorb very quickly. If that's not possible, then glucose has to be given by injection. I've done that several times. It's a magic treatment. It's like raising Lazarus from the dead. It really is. Absolutely amazing. Yeah. You go on a high then for several days after you've done that. But it's very simple. Diabetic ketoacidosis. This is the very serious complication. People used to call it hyperglycemic coma. That means high blood sugar coma. Blood sugar is not necessarily particularly high, but because the body's not able to use its available insulin in the right way, the metabolic process actually makes people very, very ill, and they can get very, very ill quickly. And it's usually well-controlled diabetics who get infections of some kind. Either gut infections or maybe an abscess or something, and they have this problem. It doesn't occur in type 2 diabetes. It can't really occur in type 2 diabetes. It can really only occur in type 1 diabetes. Increased risk of vascular disease, heart attacks and strokes, damage to the arteries supplying the limbs, especially the legs and the feet. And this is a very important part of, if you go to your doctor routinely for management of your diabetes, they're very interested in knowing, have you got good sensation in your feet, and have you got good circulation in your feet? Because there are a number of amputations that have to be performed every year because of poorly controlled diabetes affecting the circulation to the lower limbs. So it's a very important part of management. The eye problems we've also mentioned already, and the kidney damage. Routine care, regular visits to your clinics, doctor or nurse led, monitoring your glucose levels at home. I expect you all do that, do you? You do it, Tony? Yeah. And checking the HbA1c at least annually, but preferably about every 3 to 6 months. Foot checks and dietary and weight advice. I'll refer you to our previous speaker about that. Keep body mass index below 25. Don't smoke. Smoking increases the risk of vascular disease in diabetics and non-diabetics alike, but probably more so in diabetics. Take regular active exercise. act on suspicious symptoms. So if you start getting lots of infections and things, that indicates your diabetes is out of control, or if you're not a diabetic, you might have diabetes. And attend regular health screening, and a very helpful website, www.diabetes.org.uk, contains all the information you need, really. So that's my contribution for today. If you've got any questions, please let me know.